Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Welcome to VITALS. My name is Dr. John Langell. I'm the president of Northeast Ohio Medical University, and it's my pleasure to welcome you this afternoon to VITALS: Value, Innovation, Technology, Advocacy, Leadership, and Service. These are the tools that today's national leaders are using to tackle the nation's biggest healthcare problems. VITALS is an opportunity for us to convene, to come together, and to have open discourse and hear from today's leaders and how they're using the VITALS tools to help solve our biggest healthcare problems. Today, it is my honor to be able to introduce to you Dr. Ezekiel Emanuel. Dr. Emanuel is the Vice Provost of Global Initiatives and the Diane and Robert Levy University Professor at the University of Pennsylvania. He is also a Special Advisor to the Director General of the World Health Organization and a Senior Fellow at the Center for American Progress. Dr. Emanuel was the founding chair of the Department of Bioethics at the National Institutes of Health and held that position until August of 2011. Prior to that, he served as the special advisor on health policy to the director of the Office of Management and Budget and National Economic Council. He is a breast oncologist and also a noted author. Dr. Emanuel, welcome, sir. The stage is yours.
Thank you. It's a great pleasure to be here. I'm going to talk today about several topics, three in particular, as places of innovation going forward. Automation is one, telemedicine is another, and then home care at home is a third. Now, if I say automation in healthcare, the fact is everyone thinks it's an evil word. Automation suggests some existential threat to American workers, that we're going to displace them, make them unemployed. However, in an economy where we're facing labor shortages and people not working, automation turns out to be a savior, not a villain. Here is actually data on the percent of hospitals with critical staffing issues in the last 12 months. And you can see we're approaching 1 in 5 hospitals. It's, again, continuing to go up for the last 6 months or so. Indeed, the data from the Bureau of Labor Statistics suggests that about 8.2% of hospital positions are unfilled, about 1 million unfilled hospital or healthcare related positions, not just hospitals. We have a serious staffing shortage. Automation can come and help us without harming the workers. The concept behind automation is to find high volume, highly repetitive, and highly manual workflows and substitute technology and machines for those things. Now, let me emphasize high volume, highly repetitive manual workflows, the kind of mindless things that we have to do over and over again. They're not the satisfying things. They're not the fulfilling part of healthcare jobs. This frees up an overburdened, ever shrinking human workforce to realize its full potential and actually increase productivity. And I will tell you that one of the things we find is that when you go in and substitute for a person, nobody gets fired. First of all, either the job hasn't been filled or those people get redeployed to do other much more high value items. So let's take an example. Syllable. Syllable uses natural language processing capabilities to allow patients to easily schedule their own appointments or refill a prescription on the phone. Weill Cornell Hospital in New York City deployed Syllable, automated approximately 10,000 calls in 1 month, and saved Weill Cornell in 1 month the equivalent of 375 person days of work. For those of you who don't do these math calculations in your mind, that is more than one person full-time for a year. That's in 1 month, replacing one job in a not very satisfying part of activity. So automation is one thing. I think we're going to see a lot of more automation in the healthcare area. You can think of your favorite activity that should be automated. I'll tell you mine. Verification of insurance status and coverage. Every time you go in, they take your insurance card, they Xerox it front, they Xerox it back, then they plug in the numbers. Invariably, a mistake is made, and there's a loop that the front office staff have to go through. A total waste. Anyone satisfied by that? No, that's the kind of thing that'll be replaced by automation. We can see a big movement to home care. There's a lot of effort because of COVID. It catalyzes movement to home care. I had sort of predicted it about nearly a decade ago that we would have much more home care, that it would be a key element because of the need for chronic care. COVID certainly put it on steroids. We have lots of startups in this space. These efforts are related to telemedicine, remote patient monitoring, hospital at home, rehab at home, cancer chemotherapy at home, which I think would have been incomprehensible when I trained as an oncologist these 30 years ago, even emergency care at home. Now, we need to move away from point solutions. That is, someone dealing with one element to get to more integrated models of home care that allow access to any service in just one order by a physician. It's all coordinated behind the scenes. So we need incentives and infrastructure to achieve scale and successful models. We can't have a patient at home, a family member having to take off to coordinate the hospital bed, the oxygen, the toilet, the portable toilet, and all of those other things that come in piecemeal. We need a quarterback who's not the patient or their family member who can coordinate everything to happen simultaneously when it's needed by the patient and not to dribble in over days. We know that this is going, part of it is going to be telemedicine. Here's actually the telemedicine data through July 2021 or 2020. You can see the green line is telemedicine visits in the United States and the blue line is ambulatory visits. And you can see what you would predict, 100% nearly, close to 98, 97% ambulatory care visits, dropping down in March and April with COVID, and then popping back up to get to 80%. And that telemedicine went up to over 50%, 70% of all visits in the ambulatory setting, but dropping down to 20% by July. Here's actually from my institution, the University of Pennsylvania Health System. In April and May, half of our ambulatory visits were telemedicine visits. We were down half of total visits because of COVID in April and May. We popped back up to our normal 300,000 ambulatory visits per month, but the number of telemedicine visits shrunk to 13%. What this says is that financial incentives are necessary, but they're not sufficient without the necessary infrastructure, new modes of practice, new workflows. Telemedicine it's not going to zero, but 13% is hardly where it probably should be in a well-functioning healthcare system. What do we need? Well, we need hardware. whether it's medical tablets, smartphones for providers to do the telemedicine visits. We need software, electronic prescription features, electronic health record integration, documentation tools to support reimbursement processes. We need IT infrastructure, both for the physician, but also for patients. We need assurances of data security and access to technical support when things go south. There has to be payment parity. You can't have a situation where payers say, well, we're going to pay you, $100 for in-person visit, but only $50 for a telemedicine visit. They take the same amount of time roughly, and you're not going to spend a lot of time on telemedicine, especially because it has other hassles and barriers that make it hard to integrate. We also have to make telemedicine easy to use. A permanent transition, we can't have these very cumbersome processes. Patients have to easily be able to use Zoom or FaceTime or other easy mechanisms, just like we're using here, and the security has to be sufficient. We made exceptions during COVID. Those exceptions need to become permanent. And lots of regulatory changes, especially, I think, focused around interstate licensure. We'll need also remote patient monitoring if we want to get home care much more robust to cover much more comprehensive range of services. The U.S. healthcare system rapidly scaled and modified existing remote patient monitoring capacities previously developed to treat patients with complex chronic conditions. Now they're used to treat patients with COVID. Multiple studies show that remote patient monitoring is effective at preventing readmissions, improving recovery from the virus, including high satisfaction among patients. We can transform this into other care areas. For many hospital systems, the infrastructure for remote patient monitoring was already in place, allowing for effective use. As I mentioned, or I think was mentioned about me, I'm an oncologist. I trained as an oncologist. 30 years ago, I was at the Dana-Farber Cancer Institute in Boston. We used to still at that time admit patients overnight for a lot of chemotherapies. Not all of them. We did have an infusion room for outpatient things like pretty easy 5FU. But a lot of patients got admitted. We'd hydrate them, give them antiemetics, and then the chemotherapy, observe them the next day and discharge them, or keep them for 2 nights and then discharge them. The idea, if you told me in 1991, in a couple of decades, 3 decades, we're going to be giving chemotherapy at home, I would have looked at you like, you can't be serious. This isn't real. But in fact, at Penn, since July 2020 and COVID, we've given thousands of rounds of chemotherapy at home. Now, initially beginning with relatively easy chemotherapy that isn't emetogenic and problematic, leuprolide for breast and prostate cancer, rituximab for lymphoma. But this can allow us to do much more as we get comfortable with this, have a infusion nurse go out to a patient's house with an anaphylaxis bag and administer chemotherapy. You will see a lot more happening. We've got 30 cancer drugs that we have administered at home, and a lot of these are serious cancer drugs, cisplatin as an example, ifosfamide, methotrexate. These are some of these pretty rigorous, in the sense of emetogenic, hair loss, causing neutropenia, but it can be done. Now, making home care succeed requires expanding the services. We need information on patients, easy communication, remote patient monitoring on how they're doing. We clearly need infrastructure. As I emphasized, if we're going to provide complex care, we have to have one quarterback who coordinates all the care needed by the patient, unifying all the suppliers. That is really, really important. And we need incentives. We need a situation where the savings are shared and incentivize institutions to move cancer chemotherapy out of their infusion suites more to home, as an example, or divert people from the emergency room, providing things, care like for congestive heart failure or COPD exacerbations at home. Information necessary, infrastructure necessary, and incentives necessary. So I want to conclude by saying successful transformation, whether it's for automation, for more home care, for telemedicine, requires information, infrastructure, and incentives. You can't take 2 out of 3. All are necessary. And by the way, incentives alone are not sufficient. Incentives are necessary, but if you have an infrastructure that doesn't work, too clunky, too arduous to do, breaking down all the time, no matter what the incentive, it won't happen. And so I think when you think about successful transformations, you need to think about getting all 3 of these lined up. Thank you very much and really appreciate your attention. Look forward to your questions. Did I hit 17 minutes? Okay. Now it's my great honor to introduce the question and answer moderator, Betty Lynn Fisher. She's from the Akron Beacon Journal and USA Today Network, medical reporter and consumer columnist.
Hi, Dr. Ezekiel. Thank you so much for that. And you are, 12:19, so 17 minutes or maybe 18 minutes. So right on mark there. It's a pleasure to be here, filling in for Monica Robbins with WKYC, who is still recovering from her 2nd surgery with brain cancer. And so we continue to send our thoughts to Monica as she recuperates. There is a question and answer box for those of you who would like to ask a question to Dr. Emanuel, and we will try to get to them all. Let me start by one, which is, is there any room for automation in clinical spaces?
That's a really good question. And the answer is yes. There's automation. I've just been told about a company, no investment in it, so no price, that actually automates, looks at patients, predicts who might be at high risk for stroke, also predicts or activates a stroke team when EMTs arrive, so that the stroke team comes to comes to the hospital and reduces time to intervention, thrombolysis, or what have you, so that they can coordinate better. It also turns out to reduce average length of stay for stroke patients by 3 to 5 days in the hospital. So that's an example where it's not just clerical, but it's also activating the clinical system. Now they're not, doing the care, but they are coordinating the teams in a much more efficient way, which before used to probably fall to a nurse, got the call in the emergency room, activating the team one by one. So this is a efficiency on the clinical side of the house. And we should remember, for most of us clinicians, these actions, calling everyone to bring them in, alerting them about this case, that's not the satisfaction part. That's not what gives us fulfillment. I don't think we're ever going to have this automation substitute for our compassionate discussions or these complex procedures like thrombolysis for patients having stroke or myocardial infarctions having stent placement. But I do think that there are parts of what we do clinically where this might be helpful. Another one I would suggest is reporting quality metrics. It's really important to the system that we get, good data on quality metrics. Talk to any doctor. They moan about the need to go in and get the quality data and fill out. If we had automatic automation that could do that, and the physician or the nurse didn't have to actually expend the time, that's all savings of valuable time that can be spent with patients or in other ways.
Sure. One question is regarding dispatch, the emergency in a van. What staff members are in the van, and how does a patient's physician coordinate this?
Well, typically this is a nurse practitioner in the van that goes out. and has capacity to do some important interventions. I believe the van has X-ray, ultrasound. So from the imaging side, they can draw labs and run some labs on site. And then they have assessment and also intervention, whether it's sutures or other inhalation therapies, etc.
Okay. One thing in your bio that wasn't mentioned is that you are also a member. You were a member of the President Biden transition team for the COVID task force, and you just had so you're well sought after by national media, and you just had an op-ed in the Philadelphia Inquirer just earlier this week. COVID-19 is here to stay. Let's act accordingly. So, wondering if you could kind of give us some highlights from that op-ed.
Well, I mean, one of the things that Omicron has made clear is that what has often been called the no COVID strategy, the idea that we're going to eradicate COVID, is clearly wrong. We can't premise our policy interventions on that. So the first point of our op-ed and our thinking has been, we've got to reorient ourselves to how do we live with COVID and live with it in a way that allows us to live normally. And so when you begin to step back, all right, today we're not there. I think yesterday we had 2,650 deaths nationwide. It's still going up, not coming down. It'll come down. It'll come down, probably towards the end of February. But when it's going to peak exactly, it'll probably peak around 3,000. And we need to remember that, that's a very high peak. That will be the second highest peak that we've had. So we're far from this new normal. But in the new normal, what's important is for us to have as many precautions and safeguards in the background, working so we ourselves don't have to take individual action, and yet we can keep the incidence and the transmission rate low. So things like ventilation. The new normal will also be, I think, much better when we have population immunity up. That immunity is a result of two things. One is getting infected with COVID, probably not a great idea at the moment. And the other is vaccinations. If we can boost the vaccination rate, and frankly, we've been on a pretty constant plateau. The number of vaccines going into arms is at record lows, actually. People are not taking it. We need to push that. I think our lives and our perceptions of COVID would dramatically change if we had a good therapeutic. Well, we have one good therapeutic, Pfizer's Paxlovid. We have IV remdesivir, which is a little difficult to give because it requires giving it over 5 days. We have one monoclonal, which is a short supply. And again, you have to go in and get an IV, not the greatest circumstance. But what we really need is an oral multi-drug cocktail, like we have with HIV. You have just one drug. We know what the virus is going to do. It's going to mutate to make that one drug ineffective. The way to solve that is what we've done with HIV, is to have a 2 or 3 drug cocktail that's hard for the virus to escape. And that's what we need. If we had that, so you got COVID, you've turned positive, but immediately within a day could get a therapeutic treatment that would be oral. You could take it at home, last 3 or 4 days. That would be great. Or a vulnerable person, someone over 65 with some comorbidities, could prophylactically, they're going to visit their family during the holidays, prophylactically take these medications. That would dramatically change our understanding and how we go about the world. I think in addition, so I've mentioned ventilation, vaccines, therapeutics. I think another piece to this puzzle is we need some better understanding of long COVID. We don't know, for example, simple stuff about long COVID. How common is it? How common among the vaccinated? How common among the vaccinated and boosted? The numbers range anywhere from 5 to 60%. What that tells me is we have no clue. We should know that number. Second, it's very important to know how much does vaccination and boosting reduce that risk? Does it take it down to say 1 in 10,000, or does it just take it down to 1%? I think that would make a very big difference to people. If it were 1 in 1,000 or 1 in 10,000, okay, then getting infected with COVID is not that bad. If it's 2 or 3% and getting long COVID turns out to be 2 or 3%, you know, we're still, we need to do more work before I think people are going to ease up a bit. But that's where we're going.
Okay. I'll just say you had 2 more things in your op-ed. You said vaccination, ventilation, air filtration, masking, and testing, and making sure these are widespread and easily accessible for all with clear.
Yeah, on testing and masks, I think, you know, my line is they should be ubiquitous and cheap, either free or, in the case of testing, under $3 a test. In the case of masks, under $1 a test. I think on masks, we're getting there. Testing, we still need work.
Great, thank you. Next question. What do you see in the future for the mental health pandemic that the American Psychological Association has documented, e.g. depression, anxiety, substance abuse, PTSD?
Yeah, no, I think this is a serious, serious problem because it comes together with the problems of shortage of workforce in that area. You know, if I talk about shortage of workforce, we have a huge shortage in the mental health space between psychiatrists, health psychologists, psychiatric social workers, nurses who are nurse practitioners, expert in behavioral health. We have maybe 500,000, maybe 600,000 on a good day, looking through rose-colored glasses, of providers for a population of 330 million who've just been through 2 and now going into the 3rd year of trauma. Nowhere near enough. And I would particularly focus attention on adolescents. I think their lives have been enormously disrupted. You know, they tend to be a group which we say, oh, they're acting out. Oh, you know, that's the stage of life. But we actually have a lot of data that it's rough at the moment, and it's always been rough for adolescents. And we need to pay more attention on their mental health. If I had to put on the mental health category a top priority vulnerable group, it would be adolescents, junior high and high school students. And I think we probably need to do more to activate, you know, social workers in schools, school nurses, to really begin addressing these problems and really entrust them to do more with students. The last thing I would say is we have learned a lot about telebehavioral health during COVID, how successful it can be, how important it can be to have group mental health situations so people can share. I think this is absolutely a top priority.
Next question. I enjoyed your book on health systems in various countries. One of the common themes across the world is the lack of a good solution for long-term care and ensuring it. Any current thoughts?
Yes, there's a lack of good solutions for long-term care. And, you know, so let me just say, if you go around the world, there are 2 countries that have really made, at least on the financing side, serious efforts to address it. That's Germany and the Netherlands, where both have added taxes specifically focused on long-term care to fund it. Almost every other country, and that includes the Scandinavian countries, England and others, you know, we put it together with baling wire, chicken coops materials, chewing gum, and all sorts, and no one's got it done. And we're the same, right? You have to spend down to get onto Medicaid. Terrible. Everyone's moving in the same direction, which is more what's called aging in place, not going into institutions unless, you know, you've got multiple activities of daily living that you can't do, and you can't live independently. That's for patients who have severe Alzheimer's and dementia, other chronic problems. But as we have an aging of the population, that's going to be a serious, serious issue. People expect children to take care of their parents as they age. I can tell you, I have a mother who's 88. It's hard. It's complicated. It takes a lot of money. And we're not ready for it. And I think every system has a challenge of how to provide that care with an aging population and a shrinking labor pool to support that. And so I don't think there's a solution. And, the place that is probably the worst positioned on that is China. Because of the one-child policy, a couple, the woman in the couple, it's always women who do this, always. 75 to 80% of the cases, it's a woman, whether the daughter, a daughter-in-law, a sister, other relative, a niece. You've got one daughter to take care of four older relatives. That's just not viable. Especially if you want them to begin having families, China's going off the one-child policy. That is a huge strain for people. And I think it's one of the things that is weighing down on the system and will continue to weigh down. China released the one-child policy, trying to incentivize people to have more children. And guess what? Not working. And I don't think it's going to work because of the other economic and time pressures on people. So I think in China, this is one of the issues that's waiting to explode. It's not easier in the United States, but we actually have more young people per old people than almost any other advanced developed country in the world, partially because of immigration in this country.
There's mention of you being an author, and you also are an author of a book about your brothers, who includes Rahm Emanuel, for those of you who don't know, the former Obama chief of staff, mayor of Chicago, and newest ambassador to Japan. So
yeah, he's sleeping at the very moment while I'm working hard.
Will you be going to Japan anytime to visit him?
I'm going to Japan to look at good kitchen knives. That's what I'm going for.
Okay, next question. Is healthcare in America ahead of or behind global best practices and innovation?
Well, in many areas it's behind, and in some areas it's ahead. I think it really depends what you're looking at. What I've just talked about, the home care activities, we're pretty much ahead of the world, done a lot of innovation, largely because our hospitals are so damn expensive. And a day in the hospital is so costly. So there's been a big shift. Sorry, just got a call from France. A big shift out of the hospital. And so it's one of those things which I think we're ahead of. Chronic care coordination is another area where our best in this country is really the best in the world. But there are some other places that have really been working on this. Netherlands is a place that comes to mind. I would say there are also countries that are well behind the curve in this area. And so that's another thing. On the other hand, frankly, there are other places that have better choice than we do. And lots of other, lower costs at the point of care. So going in that there's no copay, no deductible. So there's not one, element here. There is a checkerboard of many things we want to look at for a best system. But we are in some areas ahead, but I'd say in a lot of areas not ahead. And they really have to do with things like choice, with cost, and easy access to services. The utilization review, prior authorization processes we have, everyone hates them. The insurer hates them, the doctor hates them, the patient hates them. We do this sort of cat and mouse game because it does save money, but it's not a desirable way to go.
Thank you for all the questions. We have a lot of robust questions in here, so I will try to get to as many as we can. Another question that says, I believe you were instrumental in the vision for Obamacare. How do you assess the success of that initiative?
I would probably, again, it depends on whether you're looking at quality, at cost, at access. On the access front, I'm not sure we did it in the most simple way. Adding exchanges, bringing people up in Medicaid, and then having the Supreme Court say, well, you can't require this. But I think what you see with 14.5 million people in the exchanges, way lower than we anticipated. what is it, 39 states having expanded Medicaid. I mean, you see real expansion of services. The other 29 million who aren't covered, a large number of them are eligible for Medicaid or eligible for the exchanges. And we need to figure out some auto enrollment mechanism to get them into this enrolled seamlessly, reduce the amount of work that anyone has to do to get the benefit. So on that, I think moderate success. If I were redesigning it, I probably would have made one big exchange for Medicaid, the exchanges, Medicare Advantage, to pool more people in and give people choices. I have the alternative is, take the 14 million people who are in the exchanges and put them on Medicaid. And make enrollment in Medicaid a sort of automatic. Either of those is the way I would have gone, because I think that would have just simplified the system. And I think right now we have by far the world's most complicated system, and we need to do more to simplify it and make it easily navigable. We have done a reasonably good job of cost control. I think, there's a lot of debate, but the fact is we haven't gone over 18% of GDP devoted to healthcare. And I think a large part of that, is a result of many things that have been tried in health because of the Affordable Care Act. Not all of them successful, but I think the trying has focused people on how to be more efficient. Some of the mechanisms I've mentioned, some of the automation processes, home care, have really kept a lot of the costs down. And I think we're going to see a lot more innovation in that space going forward. It took the healthcare system probably 5 or 6 years to sort of orient, try to figure out what the new game rules are. And now you're seeing a lot of startups that I mentioned, but a lot of big incumbents changing their practices. About a decade ago, I predicted if we would get rid of a lot of hospital beds. That's now really beginning to happen, which is probably a good thing. As I mentioned, I think taking care of more people at home is probably going to be the wave of the future. And so I think that was a change that's long overdue in our country. And I think it's probably a good thing. The improvement in quality has been mixed. We've gotten readmissions down, but we have no dramatic improvements in quality. If I were running the show now, I think one of the major initiatives I would undertake is to try to improve certain basic care items that really have a big impact. Hypertension, diabetes management. Don't do the complicated things. Focus on the bread and butter where we have the tools. We know what the numbers are that we have to hit. We know they can have a big impact on downstream healthcare costs. If we do a crummy job of controlling hypertension. There are 110 million Americans who have hypertension. 11 million of them don't even know they have hypertension. We haven't diagnosed it. And less than 70% are well controlled. Depending upon your study, it's anywhere between 30 and about 65% are well controlled. That's an embarrassment for something where, not complicated tests to know whether someone's controlled. And we have literally 200 drugs to control this, and controlling hypertension has a big, big long-term health impact. And we know we can do it. If organizations that have focused on it can get to 80, 90% good blood pressure control.
Another one that piggybacks off that with the Affordable Care Act. What would it says, as an architect of the Affordable Care Act, what would our response to the pandemic have been like if we didn't have it?
Say again? Well, if we didn't have the Affordable Care Act, look, one of the things that has been quite clear is we have huge amount of disparities in the system. Those of us who are in health policy have known this all along. It's been published out there. I'm an oncologist. The disparities based upon income status, race in getting cancer care and cancer outcomes is pretty serious. There's no doubt that if you're uninsured and you get cancer, you lose, you're much more likely to die than someone who's well insured and white, frankly. And that's not a good thing. That's unacceptable situation in this country. It has exacerbated some of those disparities. And I think we would have been way far behind the ball. We had, 20, 22 million people who had health insurance. That made it a lot easier for them to get care that they needed without having to shell out a lot of money. We have also, I think, focused, gotten hospitals and other parts of the healthcare system more efficient. We could have done a better job, but I think, there were important steps in the right direction. We had, home care has taken off since the Affordable Care Act. And again, that was critical for addressing healthcare needs during COVID. Would have been a lot worse without those changes.
Going back to automation, a question: will AI assistance with a PA type individual replace the need for primary care doctor numbers?
I don't think so. Look, I mean, I find doctors are a bit bipolar when it comes to this. On the one hand, they complain about all the overwork, the backlog of patients, they can't get to everyone, et cetera. And then when solutions are offered, like more PAs or PAs supported by things like diagnostic algorithms and guidelines, there's a lot of pushback about letting them come in, letting PAs write prescriptions, et cetera. Can't be bipolar about this. Some of the places with the most difficult or that limit associate providers, are places that have the most severe shortages of primary care and other doctors. It seems to me we want to, there will always be a role for the primary care doctor in, the difficult diagnostic dilemmas, managing more challenging patients, having complicated discussions, whether it's about end of life or living with chronic illness, and augmenting that with chronic care coordinators, nurse practitioners who can handle a lot of the routine care. Very, very important, very important. And we should be welcoming that. No doctor in this country is going to be unemployed. You can be sure of that.
Okay, next question. Talk about how best to communicate these transformative changes in healthcare delivery you proposed to patients to activate their participation.
Well, I think I'm not sure it's a communication strategy so much as a remove the barriers to utilizing this strategy. Make it, one of the things everyone talks about the money, but I think one of the things that is critical here, again, and I tried to emphasize this, is infrastructure. Removing or decreasing the barriers so these are easy to use interventions. Going into a doctor for an appointment that's 20 minutes and having to spend 3 hours or 2 hours doing it ain't fun in anyone's book. If you could do it by telemedicine and either be at home or be in the office, get a quick diagnosis, or reassurance that it's not a big deal, that's important. And I think I would spend more time thinking about removing barriers, making it easy for the patient to press 1 or 2 buttons, making sure that the high-speed internet works. I think those are probably more important to getting patient agreement. I'll give you an example of something that we did at the University of Pennsylvania, not me, but a whole nother team did at the University of Pennsylvania, postpartum blood pressure assessment for people at risk for postpartum hypertension, sending them home with an automatic blood pressure cuff so they don't have to come into the hospital to get their blood pressure measured, pinging them on the phone twice a day so that they measure the blood pressure at the same time every day, and a report when the blood pressure is high back in the health system to bring them in to intervene. That is the kind of thing, makes it easy, has a reminder for people. They don't have to come into the hospital except if something is wrong. That's the kind of intervention. And we saw compliance with that go from roughly 10% of people getting all their blood pressure measured to over 60% with that kind of simple remote patient monitoring intervention. That's the kind of thing we've got to think much harder about. No financial incentive needed for the patient. It's just like, yeah, it's better, but if I've got to drive in for a simple blood pressure assessment, not fun. On the other hand, if I can do it at home and I only have to go in if something is seriously wrong, that's, I think, a way better way to get patient engagement.
Several questions about COVID. One, men are getting more severe infections and dying more frequently than women. And this has recently
I wrote that.
This has recently been linked to men's vaccine hesitation and refusal. How can we incentivize more men to get vaccinated?
First of all, that hypothesis is almost assuredly, if anything, it's at best partial and probably not right. You go to lots of other countries where men and women have the same vaccination status, and you have a gender disparity in this situation. Men die at higher rates. Their antibodies go down at higher rates, which is not, even when they get vaccinated, that's not something because they're not getting vaccinated. That's biologic. It may be linked to testosterone. It may be linked to their immune system. We actually don't know. And by the way, everyone is frankly scared shitless of studying this because of, why should men get preferences? Well, this is a situation where they're actually doing worse by a long measure. I do think we have to get men vaccinated. Nonetheless, we have to get the entire country vaccinated. We're at 62, 63% of the population vaccinated. That ain't anywhere near good enough. And we need better communication strategies, and we need to get men, thought leaders among men, celebrities, etc., to be out there instead of having, all of these sports stars or rock musicians who know nothing proclaiming that they're, they don't need to get vaccinated. That is not right, and it's not helpful.
Another question, will you comment on the large numbers of vaccinated and boosted people who are turning up COVID positive?
Look, the point of a vaccine is not no cases. That's just not a realistic goal. And it's not a realistic goal, frankly, because of the nature of COVID. Unlike measles, where a vaccine can prevent people from getting the illness, because what's the main reason? It's got a 2 to 3 week incubation. The reason you're not going to prevent any COVID breakthrough cases is because, Omicron's got like a 3-day incubation period, not enough to activate those memory cells to produce the antibodies and then attack it. So you will have breakthrough. What the vaccines are fantastic at, and make no mistake about it, is preventing serious illness and death. Your chance, if you're vaccinated and boosted, of dying is 1 in 34,000. Just phenomenally low. And your chance of hospitalization is also incredibly low. I mean, people who are unvaccinated compared to the vaccinated have a 23 times higher risk of ending up in the hospital, 23-fold. So the vaccine works phenomenally well. You should not expect it to do what it cannot, and biologically cannot do, with a virus that has a 3-day incubation, which is prevent you from getting breakthrough. Similarly, it does appear, and I'm just going to say appear, that being vaccinated reduces your chance of long COVID. And by the way, if you get COVID, getting a vaccine soon after getting infection reduces your chance of getting long COVID also, if you haven't been vaccinated. And that, again, does appear to be a benefit. How much? We don't have a good quantification of. We need to get that good quantification. So there are lots of benefits from the vaccine. It's not, it cannot, just because of the nature of the biological nature of the SARS-CoV-2 virus, it cannot prevent all infections.
There's a question about vaccines and healthcare workers. So shortages of healthcare workers have resulted in some hospital systems calling back COVID positive workers. At the same time, they are laying off those who choose to remain unvaccinated. What comments do you have about this?
Well, the people who get laid off as unvaccinated are typically less than 1% of the working group. And any big healthcare organization, that is sort of background noise that you wouldn't notice anyway. That's the kind of churn among the workers that is sort of, below the normal rate. Okay. Second, if you're unvaccinated working in the healthcare system, you're going to be infected a lot more rapidly and be a lot sicker. So you really do need to have a highly vaccinated workforce in the healthcare setting. I don't think that's anything to compromise. I was the first to call for vaccinating healthcare workers as part of their commitment to protecting patients. I still think that's important. I wrote that in April 2021. I still think it's important, and I wouldn't compromise on that issue. You don't want to work in healthcare because you don't want to get a vaccine? All right, we're not going to miss you. I think, there are other ways of addressing the labor shortage.
This is a fun one. What are the titles of 2 of the books in the bookcase behind you, and why are they in your bookcase?
I don't know behind me. I'm looking at 2 bookcases over there too.
What about name 2 books
stacked on top? So one of the things I did last spring semester last year, basically a year ago, was I began teaching a course on Benjamin Franklin. And I'm actually going to have an online course available in a month or 2 on Benjamin Franklin. I say this, he's the most brilliant person to be born in North America. Benjamin Franklin was world-class in everything he did, and he did everything. He's a world-class printer. He created a media empire stretching from New England to the Caribbean before media empires were there. He was a politician. He was, as you all know, an inventor. He's often rated in the top 5 inventors of all time, along with Alexander Graham Bell, Edison. He's right up there. And only a small fraction of the things he invented. He was a world-class scientist who won the Nobel Prize, the equivalent of the Nobel Prize at his time, called the Copley Medal from the Royal Society in Britain. He was a world-class diplomat. He was a world-class politician. He was a world-class civic improver. Libraries, insurance companies, fire brigades, hospitals, universities, you name it, he founded it. I could go on and on. So I have a whole shelves of books about him, and just fascinated by him. I also have shelves of science, space books. My partner works on space, the history of space flight. So we have a lot of those. I like a lot of history and biography books. So one of the most interesting books I've been reading has been about the history of the Cuban Missile Crisis. There's some really new books that delve into the Russian files on the Cuban Missile Crisis. And, when you read those, you really get scared about how many people actually could have had their finger on launching nuclear weapons, lots of frontline soldiers. And it's like, whoa, that was not very well protected on either our side or their side. They had multiple submarines, each had a nuclear tipped torpedo that could go out. So, it makes you scared, and it makes you think hard about how to protect this world from disasters. Anyway, those are some of the books, some of the issues, some of the things I've been interested in.
Thank you. Let's finish off with some advice for students. What advice would you give to medicine and pharmacy students to help them stay resilient and manage all the changes that are likely to happen in their career?
So I think Ben Franklin is actually a really great model. First of all, he stayed mentally active all the way till his 84th year. 3 weeks before he died was his last published contribution, which, by the way, was a sarcastic article making fun of slave owners for all their justifications for slavery. But I think one of the overwhelming things that made Ben Franklin, or 2 of the overwhelming things that made Ben Franklin resilient were, 1, endless curiosity. He was interested in things, trying to understand how they worked, how people worked, what was going on. That's how he worked on electricity. That's how he worked on the Gulf Stream, lots and lots of things. He was always thinking, and by the way, huge contributions on medicine, the importance of lead in causing health illness. He had early viral communication of colds before. So that's one aspect. The other aspect is an immensely social guy. When he came back to Philadelphia at 80 from Paris, France, after the Revolutionary War, he added on to his house a huge dining room to entertain lots of people, social, and a 4,000 book library. Who undertakes these massive house additions at the age of 80? But this social, engaging with people, talking with people, understanding what they were thinking about. So curiosity and continuing to have resilient social engagement with friends and other people, very, very important. So add on a big dining room, bring people to your house for a meal when COVID's over, really important, or install some HEPA filters and do it during COVID.
Great. Thanks, Dr. Emanuel. I know we had a wide-ranging questions here. Thanks for answering a lot of them. I'm going to kick it back to Dr. Langell.
Thank you, Betty. And as always, thank you for your expert moderation. Dr. Emanuel, that was amazing. Such an engaging conversation about so many topics, not just healthcare, but you've got me pretty excited about learning more about one of our founding fathers. So thank you for all that you've done for us today. For everyone else, please join us next month when we'll have Nancy Schlichting, the retired Chief Executive Officer of the Henry Ford Health System and author of the acclaimed book, Unconventional Leadership, address VITALS and share her vision and her view for fixing our healthcare system. Until then, stay safe and be well.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.